We'll go to the next speaker, and that would be me. So, a quick introduction. I practice in Gulfport, Mississippi. Board certified in internal medicine, nutrition, and psychopharmacology. I'm a fellow in the Obesity Society. And I'm going to be talking to you today on nutrition therapy in the clinic. And specifically, if we don't get through this talk in time, the resource material is at booth 1000 in the display area. So what I'd like to do is change for a minute your paradigm about nutrition therapy versus weight loss. How many people in here do offer weight loss as part of their clinic? A few? How many offer nutrition therapy unrelated to weight loss? A couple? Okay. All right. When a patient comes to you and says they want to lose weight, and you ask them how much weight they want to lose, the average patient wants to lose 38% of their weight. They've been watching The Biggest Loser on TV, and they think it's just a normal, easy thing to do. When you ask a physician or a provider what they expect their patient to lose, they want them to lose somewhere in the neighborhood of about 35 to 38%. That's bariatric surgery produces about a 35% weight loss. Gastric restriction with banding causes about a 25% weight loss. So the reality is you're not going to see those type of numbers in the average patient. On the other hand, nutrition therapy, and again I'm an internist, will get you results long before you lose any meaningful weight at all. And so what I want to do is show you how that happens and why it happens. Add a potent, and I mean a potent clinical tool to your regimen that you are now using on patients and a potential revenue source. Just a quick question. How many of you are internal medicine or internal medicine subspecialties in here? Nobody. Family practice? Few. Surgeons? A surgeon, all right. Chiropractic? Naturopaths? How about nurse practitioner or physician assistant? Okay. Anything else? Okay. So we have a wide diversity, and I think you'll see some elements of this depending on the type of practice that you have. I've been doing this for 30 years, so I've seen the evolution from the very beginning of nutrition intervention to where we are today. And the one thing that I noticed, I was sharing an office with a guy who used to do Nathan Pritikin's old program, which was a very vegetarian, difficult type, it's not old, there's still Pritikin centers around, regimen that produced really dramatic clinical results. And how many people here have heard of Nathan Pritikin? More than usual. Ken Cooper? Okay, good. A few people in this group know both of those pioneers. And Dr. Pritikin said you could reverse disease with diet. And he was a PhD. He was laughed off the medical scene at the time. Dr. Cooper was stating that you could slow or reverse disease with exercise. And he actually had his license reviewed by the state medical board in Texas to see if it was a valid claim. And his license was threatened back at the time. I was in med school in the early 70s. So in that period of time, we've evolved to a point where, thank God, all of that's passed. Dr. Cooper's done more research in the world than anybody on exercise and disease, and we're up to the present. Watching this for a decade or so, I started to measure the results that I was seeing in specific medical conditions back in 1995. And I developed 13 to 15 clinical endpoints that I followed, and also was challenged with eating behaviors in patients who were struggling with how to maintain their diets. And I developed an eating inventory in 1998. And about all that time, engineered diets were coming along. They were liquid diets, the very low-calorie diets. Atkins was big on the scene, causing a big hoopla because it was against everything traditional dietetics was preaching and teaching. And they were saying that they were seeing results that nobody else could really explain, and so if you couldn't explain it, it didn't really exist. And so all of this was happening in the late 80s and all through the 90s. And about that time, we started discovering some proteins that we found affect physiology and metabolism dramatically. The nutrition boards in internal medicine, or nutrition boards in general, did not become available until 2001. And And I got psychopharmacology certified in '04 simply because I was referred so many patients that were gaining massive amounts of weight on psychotherapeutic drugs that I had to know how and why this was happening. My passion, while nutrition is my primary subspecialty, my passion is neuroendocrinology and behavioral endocrinology. And the psych drugs have kind of pushed that to the forefront since they have shown clearly that by altering receptors in the body, you change metabolism. The one thing, the empiric evolution of dietary science is that means data that supports what is being done is that you need a structure and a strategy if you're going to offer nutrition therapy or diet therapy. There has to be a system of accountability, whether it be individual or group. It has to have some objective way of measuring it. Weight Watchers does it with a point system. It's very good and clever. The program you use has to have some nutritional credibility. And again, through that evolution, both the very low-calorie diets and Atkins have proven scientifically what they do and how they do it. So they have gained that credibility as well as the usual traditional recommendations for nutrition intervention. But the thing that's really been a crystallizer of all this is the discovery of cytokines and the evolution of cytokine endocrinology over the last 10 years. How many people in here know what a cytokine is? Okay, about half. The first time I gave this lecture in '03 to a bunch of cardiologists, 3 out of 100 people in the audience raised a hand that they knew what a cytokine was. If you pick up the cardiology literature now, virtually every article in the literature is talking about the inflammatory process of atherosclerosis and the role cytokines play. I'm on the editorial board for the Atherosclerosis Society for their journal, and the journal now is probably half cytokines, and that's only in an evolution from '03 to now. So 6 years we've learned how this happens. More importantly to me, the clinical measures that I determined in the mid-'90s, I now can explain and understand as to what I was seeing and why I was seeing it.